So we'll make a start. So this session is CTO live cases we have finished. So this is special techniques, nuts and bolts. So if I can invite the first speaker if he's around, Dr. A.B. Gopal Murugan on Dante's technique and Kusabi balloon. So probably he's not here, so we'll move on to the second speaker. Have you got the second speaker, Mr. Dr. P.K. Asokan? Okay, probably they are still stuck up. Okay, do we have a third speaker then? Dr. K. Damodaran? Okay, let's put the third speaker. So the topic here is how to manage guide catheter and tips and tricks. Dr. Damodaran. Who's the organizer here? Can you call up the speakers? No. The first and second speakers, if you could just give them a call.
Can I?
Yeah, sure. Okay.
Good evening. My assignment is to talk on guiding catheter management, length management. Obviously, why should we know about the guiding catheter in IJCTO PCA? Because in certain cases, we need to cut short the guiding catheter or extend it in various lesion subsets, and there are certain indications in which we have to cut short the guiding catheter. Mostly, if we have to do a distal lesion in a native vessel through a long graft in a post-CABG patient through a venous graft or a lima, then we may not be able to reach with a standard catheter. So we have to either use a specialized guiding catheter which is available, which is usually not available in many places. So we need to learn the technique of cutting short the guiding catheter. And also in retrograde IJCTO PCI, when we need to approach the posterior lesion through a retrograde approach, especially when we are going through a long collateral route, that is an epicardial channel, or through an enlarged heart, we need to shorten the guiding catheter so that our standard devices like stents and balloons could reach the lesion. Also, it will be useful as a modified mother and child technique. The ideal thing is to have a specialized catheters, but the lack of availability makes us to learn the guiding catheter shortening techniques. You all know the standard length of a hardwares. The standard guiding catheter is 100 centimeter. With a mother and child, it goes up to 120. With the assembly of a guiding catheter and a Y connector, it may come around 125 centimeter. We have a stent catheter which is almost available up to 140 to 125 centimeter. So the only distance which we can do, stentable distance, is 25 to 30 centimeter beyond the ostium of either LCA and RCA as from the simple arithmetics. This is the usual stent catheter of various manufacturers, almost starts from 138 to 145 centimeter. So to reach a distal lesion, we need to know this guiding catheter shortening technique. Obviously, if you have a specialized catheter or a mother and child technique, it may be useful. But when we have already engaged the guiding catheter, when the wire has crossed the lesion, we cannot change. It is cumbersome to change to a specialized catheter. So we need to shorten the guiding catheter, which is already engaged the guide, which has already engaged the coronary. So this is an example of CTO proximal RCA, which is being attempted through a retrograde approach through a epicardial channel. And again, it is a native vessel, which is the distal lesion is being done through a lima. These are the situations we need to go through, use a guiding catheter shortening technique. Basically, the guiding catheter shortening techniques are three types, and the concept has been initially formulated by Stati and Co. He initially, what he did, he cut short the guiding catheter at some distance from the hub of the guiding catheter. I will explain from that diagram. You can see the lowermost one is that he cut short the guiding catheter from some distance, then reconnected with a short sheath, which is usually 1 French less than the guiding catheter size. And the second technique is the usual technique what we are practicing is to cut the desired length of the guiding catheter at some distance from the original guiding catheter hub and to interconnect the guiding catheter with the short sheath stuff. The third one is to maintain the original hub itself without interposing a sheath, that is cutting short the guiding catheter and to reconnect the curtain with the original hub itself. Obviously, these three techniques have some advantages and disadvantages. The disadvantage of connecting a guiding catheter with a sheath is obviously we may not be able to use a Y connector because we have to push the devices like a balloon and stent through the sheath rather than the Y connector. So it is little cumbersome when compared to the Y connector. The other thing is the commonly practiced is who et al. Who has done the usual one that I have shown as a second option. So these are the various steps. This is the proximal end that is being cut, and then once the catheter is engaged, if you cut the hub of the guiding catheter at some distance, obviously there may be a back bleed. So we need to clamp it. Sometimes clamping the catheter may damage the catheter. Then later on, if you push the device through the catheter, it is very difficult. So it is ideal to put a balloon and inflate it inside the guiding catheter so that the back bleeding will be avoided when the catheter is already engaged. And then I will explain this through a standard video you might have seen in this video. This is whatever the catheter, like a 6-inch catheter you have taken, then you have to measure the distance you have to remove and then cut and the distance from the hub as well as this side. Then you have to remove that and you have to interpose with the sheath star. The sheath is cut at two ends. This sheath should be 1 French smaller size than the original guiding catheter. We have to cut here as well as at the distal end. The distal end is usually tapered, so we have to cut at some distance. Now, being 1 French smaller, we need to flare both ends with the dilator. The flaring should be very careful because sometimes if you flare with the arterial forceps and other things, it may damage the ends. And once we connect it, there might be air embolism if you inject something, or if the sheath is crushed, then the devices may not be able to take it through the connecting end. So we have to be very careful in this and then reconnect both the ends. Now the shortened guiding catheter is ready. This is a case example where we did that it's a 56-year-old male diabetic old anti-volamine severely. I had a CTO of both LAD and RC with a mild L6 disease. Cardiac showed no viability in the LAD. So we thought of doing a RCA. Because the RCA is osteoproximal lesion which is extensive, we thought of doing it through a retrograde collaterals. You can see the retrograde collaterals through the circumflex artery. And there is a long, this one. So we did, you can see the long collateral route. So obviously, knowing that we have cut short the guiding catheter even before that, and retrograde PCA was done, and finally this is the result. Just mention about the guiding catheter extension. The guiding catheter extension also can be done through the supporting catheters like guideline and guidezilla. This is especially useful in difficult anatomy like anomalous origin coronary artery with a CTO, or in a CTO with a tortuous proximal segment. If you want to take the devices into the distal lesion also, we need this guidezilla. Sometimes it may be useful to deliver devices even rotabor through the guidezilla. And in contemporary reverse cart, we can externalize the wire using a guideliner or a guidezilla. The techniques, I don't need to go into that. This is a common technique, that is the deflated balloon keeping the ostium of this one. And the case, this is, you can see the anomalous origin of RCA with mid RCA CTO. We have initially engaged with the JL, obviously which may not have a backup. Now you can see the guideliner which is sitting there with that the mid RCA was opened up, and finally the study was done. So the guideliner or guidezilla is not only useful for taking the devices, also having some good support in an anomalous situation like anomalous origin or a distal leg. distal lesion. The take-home message is both guiding catheter shortening as well as extension is feasible even if the guiding catheter is already engaged in the coronary artery, even if the lesion has been crossed by a guide wire. And it is useful in the situations, whatever I have mentioned there, in native vessels in a post-bypass or in a very, very proximal lesion in a retrograde approach. And the extension, as I told you, may be useful in patients with poor backup support. Thank you.
A very nice presentation. You very clearly, especially the video was very explanatory. Just two comments on this. As you rightly said, when you're using a 7 French guide, you take that sheath where you want to do an extension is 6 French. And the dilator has to be 7 French. So dilator has to be 7 from both the sides. So it can fit and snug into it, one. Secondly, the way where I routinely shorten my catheter is for every retrograde case. Because when you're externalizing it, you want that your external wire, the RG3 wire, because the tip is very soft. You want the wire to come out very nicely. For this should be a routine practice if you're doing CTOs with retrograde for externalization. Keep a routine practice for your feeder catheter and you should shorten it out. Your comments, Dr. Balbir? Any comments or any questions from the floor? Thank you so much. Thank you. So I'll invite the next speaker. In fact, the second case, Dr. P.K. Asokan, and he's going to speak about how to perform CTO PCI in a cardiorenal failure.
Good afternoon to you all. This management of CAD in patients with CKD can be challenging. Patients with advanced CKD often excluded from major trials. Knowledge in these populations mainly based on extrapolation from general population, small non-randomized trials and subgroup analysis. You know that its prevalence is dialysis patients around 63%, asymptomatic end-stage renal is 50%. Most important thing is mildly reduced eGFR are at increased risk for obstructive CAD. You know that the mortality is mainly related to arrhythmias and cardiac arrest in hemodialysis patients. You know that what are the pathogenesis in CAD patients? There are traditional risk factors and non-traditional risk factors. Most are pro-inflammatory and pro-atherogenic and can produce a medial calcification in this case. There are different classifications of CKD patients. They should have a structural or functional abnormality persisting for more than 3 months with evidence of impaired renal functions. This cardiorenal or renocardial syndrome may be different. I'm not going into the details of that. Most important thing, the volume of atheroma, the nature of atheroma is almost same as in non-CKD patient, except the calcification, the amount of calcification in intima and the media. The media calcification is unique to the CKD patients. You know that there are mediators for CAD associated with myocardial coronary damage. Can produce vasculopathies, endothelial dysfunction, microvascular dysfunction, or myocardial abnormalities because of interstitial fibrosis and LV dysfunction. So, what is the strategy? Revascular strategy. Patient with multivessel disease, we know that they are associated with almost decreased mortality in long term, and repeat revascularization perhaps MI with no long term mortality differences. If you do PCI in CKD patient, there is a significant increased risk of cerebrovascular events, bleeding complication, patient with impaired renal function, especially in hemodialysis patient. There is a recurrent ischemia and observed in 63% of patients, MI in 23%, and death in 13% patients. The 1-year mortality was inversely correlated with eGFR 1.5 in normal versus 19% in dialysis patient. The CABG, what is the outcome? The upper mortality is also high, especially in stage 4 and 5. The upper mortality is 9%. In hemodialysis patient undergoing CAG, there is a high perioperative mortality, which is 3 times higher than non-uremic patient. Now, we'll see if you do intervention in this patient. the long-term mortality is almost same whether you do CABG or stenting. If you see this stenting CABG in terms of risk of MI is slightly high on long-term stenting. If you see this CABG long-term risk for stroke is high in CABG patient on CKD. Then stenting with long-term risk for repeat revascularization is more than stenting. So interaction of CAD, stroke occlusion in CAD patient undergoing primary PCI. Patient with primary PCI come across CTO, what's outcome? The prevalence of non-infarctic CTO is 13% CKD patient versus 7% in those without CKD. The clinical impact of CTO seems to be overshadowed by presence of CKD. You see that the survival curve follow up in years. A patient with normal GFR, the survival is 95% versus when there is a reduction in EFR, a patient if you do only primary angioplasty. But survival is STEMI patient after primary angioplasty with a reduced EFR. If there is a multivessel disease alone, the survival is around 92%. But if there is one lesion is CTO, the survival is come down to 71%. If you see the survival patients after primary angioplasty, if there is associated reduction in EFR, if EFR is less than 60, the survival rate is sharply reduced to 33% from 71%. So, what is the prevalence of CKD in studies? Shown that CTO, then despite high prevalence of CTO in patients CKD is 12 to 19%, but there is less known outcome of patient CKD. The prevalence of CKD in CTO, the other way, is also varies from 1.8 to 8.7. So the reason to perform or not to perform CTO PCI is patient with CKD is better outcome. We have seen already, better quality of life. But the points against are most of the patients are fragile, risk for acute kidney injury, and risk for hemodialysis. So the prognostic impact of CTO patient in whether you do CABG or PCI, patient with CKD received medicine, that there's a base rate and survival is less versus revascularization. Patient received CKD, if you do CABG or PCI, then the survival is better. There's not much difference. But if there is we attended CTO and if there is a failed CTO, then this accumulated survival or MACE rate is high. So, what is the outcome? Reported that 16% of patient overall, whether it is 26% severe GFR reduction or moderate GFR reduction, the average is 16%, patient develop acute kidney injury in the form of chronic intestinal nephritis if you do the CTO. So the incidence is varies from if normal 4.6 versus up to 16.7%. If you fail that, the success rate in attended CTO, then the risk is around 89%. Even if there is a CTO we are not done, and if there is a kidney dysfunction, the risk factor is, even if you are successful, risk factor increases. So there is a what's contrast induced nephropathy is a 25% relative increase in or 0.5 milligram increase, absolute increase in serum creatinine in 74 hours after the procedure. Different grading, and there are different mechanisms. Not going to that. Most of them are the medullary ischemia because of different mechanisms, or increased tubular injury reducing the GFR. So there are different scorings, and there is a pre-procedure score, and the renal protection measures should be taken, and unfortunately no protective measures showed any evidence of reducing injury. Most important is fluid administration, pharmacology strategy, renal replacement, and use of different contrast agents. So most important thing is intravenous hydration. This is a class 1 indication in ESC. Use of low molecular isosmolar contrast, and contrast volume should be less than 300 or 350 ml or 4 ml per kg. Or there is a formula to calculate this. It's a class 1 indication. If you use a high dose statin, or the volume should be minimized, or rosuvastatin can be given high dose class 2A. And in patient with higher risk of injury, when prophylactic hydration is impossible, you can use along with this furosemide with hydration. Patient has got LV dysfunction or CCF, or patient with in this situation, we can give furosemide. Or if urine output is less, then in that situation you have to give hemofiltration prior to the procedure, and that's a class 2B. Now previously it is class 2A, now it's a B with a level of evidence B. NSTCT without hydration not recommended, but high dose of NSTCT with what you call that hydration is used in sometimes. Infusion of soda bicarb is a class 3 indication. It's not at all recommended. In severe CKD, prophylactic renal hemodialysis no role. So usually it occurs within 24 hours, peak in 3 to 4 hours. Serum creatinine is an imperfect marker for renal function. You have to estimate, calculate the eGFR using the formula. And so different contrast, whether you use low molecular isotopes, there is no much difference.
We got 30 seconds, sir.
Yeah. I come to the last slide. So what should be the strategy? All patients with EGFR, where there is reduced single function kidney, you should assess the risk factors. You have to give adequate hydration in the form of intravenous normoxylide, not oral. And you should start at least 24 hours, sometimes at least 6 hours, or ideally 24 hours before the procedure. Should continue for 6 hours or 24 hours post procedure. And you should discuss with nephrology team concept for bicarbonate and prophylactic renal replacement in some cases. And you should use iso-osmolar, low osmolar, avoid antigen injection, use hybrid technique. And IVUS is the things coming to reduce the contrast volume and small diameter retrograde catheters, or you can stage the procedure if contrast volume is high. And in the procedure, you should reduce, most important is reduce the contrast volume. So the conclusion, most important thing is case selection. You should know which case. You should have evidence of inducible ischemia, or you should have viable myocardium, and should evaluate for the risk factors like anemia or metabolic parameters, correct anemia and metabolic factors. Should hydrate the patient before the procedure. Hemofiltration as a preventive measures if patient has got LV dysfunction or congestive cardiac failure, where he can give more intravenous fluid. Femoral route is indicated in patients rather than radial route, because you may have to use the fistula, the radial fistula in these cases sometimes. Guiding catheter without sidewall to reduce the contrast. Selection of adequate hardware is very important, and because our technique is changing now moving towards a fast escalation, where your procedure time is less, the contrast volume is less, and subintimal dissection re-entry may reduce the incidence of contrast renal failure. We don't have a data at present, and IVUS also may reduce, and tip injection in stage. Most important thing, patient comes with acute MI, can stage the procedure. Thank you.
So what is the incidence of, let's say, patients requiring dialysis in a EGFR of 30 to 60, that group? Because this is the most prone group, because you get them really worse. Less than 30, anyway, they are going to get into dialysis sooner or later. So what is the risk of dialysis in this group of patients? How many percentage of patients would get into dialysis if you treat a CTO?
So that's what I showed. The acute kidney injury average is around 16%.
And if they undergo bypass surgery?
If you do the contrast volume is less, and take all precaution, we can reduce this incidence further. That is one important thing. Once patient develops contrast induced nephropathy, the mortality is very high. And out of this, only 7% of patients requires hemodialysis, temporary hemodialysis, or may end up with end-stage renal failure. Most of the patients will recover. Most key, important thing is the volume of the contrast should be less than 300 and hydration. That's one thing.
There was small study, whether I don't know whether you're aware of, coronary sinus aspiration. Do you know anything about that?
Pardon?
Coronary sinus aspiration. They leave an aspiration catheter in the coronary sinus. So whatever contrast is injected, the catheter in the coronary sinus would, suck everything out. So small study, again, there was not much evidence. Very well presented. You give all the method. Other things, especially when you're doing a CTO, other thing which you could use to reduce your contrast load, again, doing a retrograde. For example, if your feeders are septals from the LED and you're doing a RCA CTO, it's worth getting a guideliner or guidezilla into the LED and giving your retrograde injection from the guideliner. Because if you're giving an injection from the left coronary artery, your circumflex, everything is filling, and most of the contrast load is giving retrograde injections. So if you get a guidezilla or guideliner into the LED, so that contrast load would be less. So that's another point to remember. Any questions from the floor? Thank you.
Anchoring.
Yeah.
So we move on to the next important technique, which is the anchoring technique. I request Dr. Lakshman Das to come kindly present and enlighten us about anchoring.
Good evening, friends. My topic had been adequately covered by many speakers throughout this program. Yesterday, Dr. Ashwin also talked about the anchoring technique while he was talking about this. When we'll need the anchoring? The anchoring will be needing when the IJCTO score increases, you will need anchoring. So like a reattempt or increase in the bend, calcification, and of course, if there is a long CTO or the entry shape, it is tapering or not, then you will need anchoring. Anchoring should be done at every step. Don't underestimate the effect of the sheath, long sheaths, and guiding catheter, or which route you are going to take. All these are very important. Never underestimate the length of the sheath. They give the stability and take away the tortuosity, which may be a hindrance for your progress of the CTO program. And there are long lengths, probably they are can be used. And of course, guide catheters, mostly it is a 7 French or 8 French. If you got ampoules are mostly used for the right and then EVU for the left. And a femoral approach is preferable because you can take a larger device to deliver all your devices. And if you are having a radialist, then you can have a radial which can be used for the, to the right radial can be used for the left coronary artery, and you can use the femoral for the right coronary artery. And trapping balloons, you should be careful, particularly when you are using the radial, and which may, if you use a 6 French, it may suck air and it may be a deterrent. And of course, you know that the active and passive supports which is being given by the guiding catheters, I need not go much in detail. And of course, wires has to be used sometimes for anchoring. You can use a side branch anchoring can be done by the wire, or you can use a body wire to give the support for the progress of that first wire. And you can use a seesaw wiring by using the micro catheter along with the wires. And of course, you can use a crochet catheters, double lumen catheters, to anchor one of in the branches, and then next one can be used for the wiring. This is one of the cases where the side branch is used for the near total occlusion into the branch, where it's finding it difficult, and subsequently the wire enters because of the support being given, because without backing up the guiding. Even with this, there is some kind of backing up is seen. The wire progress as well. Then you just finish the program with your stenting finally. Then body wires, you can see that the wire which has gone into the subintimal space, they may anchor the guiding well, and then the second wire may be able to penetrate the lesion. And of course, with that, you can see the seesaw wiring, where with the microcatheter, you can travel a distance, and then next catheter travel the further distance. You can pull that first one and then travel the further the distance, and then you can enter the distal cap. So you can do a seesaw wiring alternating with each other, and then you can reach the final destination. This is a dual lumen catheter, where they were able to see that the side port, they have entered the septal, and then they have penetrated with a central lumen into the distal branch, and then finally they have finished this program. And anchoring, there are several types of anchoring. The balloon can be used, because anchoring can be used in the side branch, so that guiding cannot be kicked back. And of course, it can be used as a coaxial anchor technique, where the proximal the balloon can be staged in the proximal portion of the CTO, and then that will give a support or anchor for that wire to go further. There are special guide catheters, special balloon catheters like Prodigy, which can be used in a vessel from 2 to 6 millimeters, because of the elastometric balloon, and which is 5 French compatible system. So this also will be able to stabilize the wire, and then you will be able to penetrate the proximal cap. And of course, distal balloon anchoring, you can use that, where you take the balloon distally and then anchor that, so that it will give a stability for the stent to cross through the tortuous bends and then go to the destination. Now, of course, you can use that antegrade anchoring for the retrograde cases, where if a retrograde wire crosses the lesion and accelerates into the guide catheter, an antegrade balloon can trap the RG wire, so that it provides a good support for the retrograde delivery of the balloon, or stents can be done. Same thing can be done in the opposite. Retrograde anchoring of the antegrade wire also possible, where from the retrograde position you can put the balloon and then steady that, so that antegrade wire it will be helped to pass the balloon and stents. And of course, you can use the stent also for that purpose. Suppose that you are not able to deliver the stent distally, and what you can do is you can place that stent in the proximal portion, which will trap the second wire, and then that will give anchoring enough support, so that further the distal stent can be supported for the passing of the proximal stent distally. So the proximal stenting can be used to support that for anchoring also. And of course, you've seen that mother and child catheter, which can be used for the support, and there are several types of there, hot rail, guidezilla, guide liner. All these can be used for the mother and guide technique, where it changes the shape of the guiding, that gives further support, and deep intubation also gives increases support, so it will be useful to cross. This is one of the cases I'll show you. This is a total occlusion in the mid and distal portion of the RCA, and then it is wired, very tortuous course, and then you can see the calcium throughout from the proximal to distal. The wire we were able to pass it, then we have sequentially dilated, and you can see that now what I have done is I have used the balloon for anchoring distally, and I have used that guide liner also. So I have used the two anchoring techniques to take that guide liner deeply, and then I delivered the stent. So one after another, I delivered the distal stent, and I have brought the proximal stent also again with the help of the guide liner. And this is the final results. And the anchoring, that may have a impact in the anchored vessel also. You have to be careful about that. Possible damage to the anchored vessel can be possible. It could be the only source of the collateral, so you should be very careful. You may be producing the ischemia, and the patient may become unstable. distal anchoring may sometimes result in extensive stenting also, because when your anchored area may get dissected, and watch out for always the coronary artery dissection when you are focusing on the distal one, and then you may dissect the proximal one. Thank you for your attention.
We can have a question if anybody is interested. Yeah, please.
The conus was, the wire had gone to the conus and anchoring balloon was put in that. What is the incidence of ischemia and how to prevent ischemia in those branches?
It's very small branch, so it doesn't really matter.
Even conus does
Yes,
not matter?
unless the conus is collateralizing the LED.
Okay.
Balloon, you can inflate the balloon only when you pass the material. Otherwise, you keep inflating to the side.
No, but you're doing the whole procedure, you keep inflating, deflating, and you many times will forget when you inflate it, when you are more interested. So unless the branch is big, a small conal branch, it doesn't really matter. Yeah. Because you are concentrating there, so half the times your mind is whether the balloon was deflated.
If you want to do something, you have to inflate.
I understand what you're saying, but even if you leave it inflated, it's not going to matter really.
It's just not you pushing anything in or out. For example, even if you're manipulating the wires, because the guide, especially if you're doing in RCA, and if you don't have a brilliant guide support, even if you're manipulating the wires, your whole device and everything would fall out. But if you have an anchoring balloon, if you remember the first case that we saw, the anchoring balloon was there, everything came out. But because of the anchoring balloon, the guide was still there, and the operator could get everything back inside. Otherwise, he would have to again engage.
Please.
I think it was your case, isn't it, Dr. Laman?
You keep the balloon inflated, it doesn't matter at all. There was a very large branch.
This is a genuine problem if you are doing lab system. When you have a balloon which you have used as anchor in a moderately large diagonal,
Yeah.
then it is a big
septum.
pain,
Even the septum
and you have
can-
to intermittently deflate it.
You're right, absolutely. And I think in left system, the guideliner is a great help.
Yeah.
Both for circumflex and both for LED.
And you are anchoring only at 4 to 6 atmospheres. It's not very high that you will cause you.
Small balloons.
Thank you.
Thank you very much.
Okay, we'll call the next speaker now, Dr. Ajit, who will speak about antegrade retrograde wire connections, tips and tricks.
Good evening all. My topic is antegrade retrograde wire connection, tips and tricks. So the wire connection antegrade and retrograde is undertaken in long CTOs when you have an ambiguous proximal cap, when you have good interventional retrograde channels, previous failed antegrade, large dissection space, long CTO with the distal cap near bifurcation. These are essentially the indications for a retrograde approach. So direct wire connection, when you are really crossing the directly from the retrograde wire, it's easy, but it's rare. I mean, it's usually happens by chance. It usually occurs for short occlusions, not many tortuosities, and not much calcium. In my experience, it happens only in 5% of the cases. So this is an example of proximal right coronary artery occlusions, and antegrade approach was failed earlier because of the branch point and ambiguous proximal cap. But the dual injection showed that it was a very short occlusion. So the retrograde wire could directly get into the antegrade guide catheter, so then it was trapped and subsequently stented. Now this is a main area we should all remember, reverse cart or the X cart. The conventional form of antegrade retrograde wire connection, more than 80% of cases. So once we cross retrogradely, we made an antegrade retrograde kissing, and then essentially we follow the reverse cart. Now, what is contemporary reverse cart? There are some points you should understand. Understanding the CTO anatomy, that's by using IVERS, using CT, using angio information, setting up the antegrade platform. Again, IVERS get entry when possible. If you have a branch point, you pass the IVERS, get the wire into the vessel, and then you set up a retrograde platform. Distal entry beyond the bifurcation or disease segment. So even when you go retrogradely, you should know the vessel architecture. When you go subintimally, still inside the vessel, So the morning lectures, you would have known that the media, and you are actually expanding the vessel under the external elastic membrane. So that is the key for us. Whether you do an angiogram or you IVUS, EM is a boundary for us. You play within the EM, otherwise you end up in rupturing the vessel. So the connection, antegrade retrograde connection, you make within the vessel architecture, to be precise, within the external elastic membrane. So close proximity of the bilateral wires and retrograde crosshair, antegrade small balloon dilatation, retrograde wire puncture over the dilated balloon, and then do balloon inside the CTO segment. So that is the essential crux of contemporary reverse cut. That means you do a connection of anti-retro within the CTO segment. You never extend the base of operation too proximally or too distally. So this is the definition of contemporary reverse cut. So this is a picture, is quite familiar for all of you. You do an antegrade ballooning in the subintimal space, and then you connect the retrograde wire, and then you connect it. Okay. So this is a contemporary reverse cut. If you see, the ballooning is essentially within the CTO segment. So that is contemporary reverse cut. So this is actually a contemporary reverse cut of the distal precrux RCA. We could see that antegrade wire having a sinusoidal path, and then we could balloon the antegrade, balloon across the antegrade, and then do a connection. You can always use IVUS here to size the contemporary reverse cut balloon sizing. So, okay. Now, how is different from the classical reverse cut? So in contemporary reverse cut is a modified version where you will modify wire passage in and around a deflated balloon, like we saw here. So you are actually modifying the retrograde wire passage by inflating and deflating within the CTO segment, and then you allow the retrograde wire. So most of the work is actually done by the operator, where he is maneuvering the retrograde wire while inflating, deflating the antegrade balloon. So that is contemporary reverse cut. Whereas so here actually the most important is actually wire control. So the important term is actually wire control. So in contemporary reverse cut, solution to fail reverse cut is to increase the retrograde wire control to allow wiring into the antegrade space. You can use a floppy wire, you can use an Ultimus Pro or intermediate wire, you can use a Congress Pro. So wire is the key. Balloon is just a medium to which you can make a connection. In classical, actually, you increase the balloon size. So this is 2 years or 3 years back, we were all using classical reverse cut, in which actually you increase the balloon size. Suppose you take a 2.5, it is not getting anti-retro connection is not made, you increase to 3 and then you connect. Okay, so that is actually, but the problem with classical is actually you increase the antegrade space, more hematomas, more slow flow, more problems. So contemporary reverse cut is much more controlled way of cutting. Now, what about the tips of contemporary reverse cut? It's again secret of wire control. Backup force should be good. Corset should be drilled into the CTO. So the retrograde catheter, microcatheter has to go near the CTO, distal cap. That is very important to get the backup force. And virgin territory. That means minimal retrograde wiring should be done, not to expand the retrograde wire space. You at least antegrade and retrograde, at least make sure that at least one wire is in the true lumen or in the intima. Most likely it is going to be the retrograde wire, because antegrade platforming and preparation we do, and majority of the cases antegrade wire will be in the false lumen. Antegrade preparation, set up wiring in the straight segment, avoid tortuous segments for reverse cutting, and then of course end balloon wiring. End balloon wiring is nothing but you deflate the balloon. The moment you deflate, you try to advance the retrograde wire into the into the antegrade wire compartment, and try to finish within the CTO segment. So this is actually the tips for contemporary reverse cut. Now what about when you fail a reverse cut, a contemporary reverse cut? It's important is to use the IVUS. Now when you have IVUS is actually the last modality when you try to bail out the situation. When you have an ambiguous course, when you have a failed reverse cut, you try to understand the position of the antegrade wire and the retrograde wire, and then you connect it. So there are basically in the concept of vessel architecture is very important. You can have 4 combinations where depending on the position of the antegrade wire as well as the retrograde wire with respect to the intimal space. Now what about the antegrade wire in the calcified intima and the retrograde wire actually in the false lumen? So here actually what you do here is actually an example of the situation where the antegrade wire is in the intima, whereas the retrograde wire is in the subintimal space. So here the antegrade Gaia third and the retrograde was XT. So and Miracle 6 was failed to connect after a reverse cut. Now retrograde wire was changed into a confiance clamp. So again wire control. The wire control has come, and then you have increased the tip load of the retrograde wire, and then you make a connection. Now the IVAS clearly shows that at serial IVAS images we can clearly point out the position of the retrograde wire, where at this point A you find that the retrograde wire is actually raising a plug and coming up, and you can always connect that you can make sure that both the wires are actually connected within the subintimal space at one place. So that is very crucial. Now, what about the retrograde wire in the calcified intima? So here the retrograde wire is in the intimal phase, and the antegrade wire is in the subintimal space. Here again, upgraded. It's actually a failed classical X card. Then we actually again we have increased the tip load of the antegrade wire to make it connect. So IVAS overconfidence up again. So here again we are trying to use an IVAS, and retrograde true lumen was compressed. So we can see that the true lumen was extremely compressed, and there is a large subintimal space, over 4 centimeter. So what do we do? So here actually we found that proximally there is a large subintimal space, we could not make a connection. So we changed the base of operation. Base of operation is the zone of the vessel in which you try to connect the antegrade wire as a retrograde wire. So the term is quite common in the hybrid approach, base of operations. We should be familiar with that. Now here the base of operation was changed distally. So changing of the re-entry zone, shift of operations from distal to the RC, reverse card was done again, and we have made a successful connection. So more the difficult part is actually both antegrade and retrograde wire in the subintimal space and far apart. Here IVAS may help to connect. Always remember that EEM is very important. In an IVAS, EEM is very important. Your wire has to be within that. If one wire is actually completely outside, the more difficult you will be in making a connection. Antegrade knuckling. So and the retrograde wire can be knuckled into the CTO wire. So these are some of the solutions, bailout solutions. You can knuckle either of the wire depending on which is more closest to the lumen. If you think that the antegrade wire is closer, where the retro is more outside the media, then you try to knuckle the one which is closer to the lumen. So it becomes a big knuckle. Then you create that space as bigger. Then you try to advance the other wire. The antegrade stiff wire can be made to puncture into and connect the two false lumen. Very rarely we use card for connections. Here as a retrograde FC knuckle and then antegrade miracle toe. So through the miracle retrograde knuckle, you try to connect the very high penetration wire from antegrade approach. This is actually again a rare connection method you connect. That is actually a tip in or rendezvous. We are trying to push the microcatheters deep in and then try to wire into the antegrade microcatheter. This is a remote rendezvous in which the catheter actually is in not in the CTO segment. You make a connection within somewhere in the guide catheter, either in the ascending aorta or in the arch. Now, how to bail out a failed or difficult reverse card? This is IJCTO algorithms. A little difficult, but then you should understand that it all depends on the IVAS examination. When you have a problem with the contemporary reverse card, you always try to do an antegrade IVAS examination. If the antegrade wire is subintimal, and then again you find out that you have to use a retrograde congress wire, you high penetration wire and a big antegrade balloon. Again, it doesn't work. Like in our case, we showed, we move the base of operation. Then again, you try transit balloon, IVAS retrograde. Basically, you take a bigger balloon, or you go back from move the base of operation. That means you are moving away from the contemporary reverse card technique, more or less going to the classical way. Either you change the base of operations or increase the size of the reverse card balloon. And always remember that if there is a significant length of the dissection process proximal to the connection point, proximal RCA, you try to use a bigger balloon and try to connect. The last and the least would be to use a guide liner reverse card or a stent reverse card, where you limit the movement of the retrograde wire by pushing a guide liner and trying to advance the retrograde wire into the guide liner. Or you can fix a large subintimal space in the proximal RCA or mostly RCA by a stent, and then you try to connect. The LAD always, the left main will come, circumflex will come, so these issues will be a little challenging. So to find out bailout, we have a used guide line card for a large subintimal dissection place, antegrade wire subintimal and retrograde connected, difficult exit for retro wire into the guide. For stent card, it's a last resort again, large proximal plaque, large antegrade subintimal space, retrograde wire subintimal and knuckle is very difficult and should be used as the last resort. Thank you.
Any questions from the floor? Very well presented. You went through all the techniques, which was very fantastic. You rightly said it's very easy if you are true to true, which is very easy. And what I found very easy is if you are subintimal in both antegrade and retrograde. I'll tell you why. Because it's very difficult or sometimes challenging if your wire is antegrade, then you have to still get into the subintimal space or into the intimal space if either of them is outside. If both are subintimal, if you go through antegrade, you knuckle it, you get your corsair close to that knuckle, you get a balloon antegradely, you inflate the balloon, and if you see, because your subintimal space is 360 degree, so you really don't know where your wire is going to fall off. So once you are ballooning it and you deflate it, you will see your corsair retrogradely fall into the space, and that is when you quickly get your retrograde wire into the antegrade. So that's one of the other tips which works to connect it. What do you think, Dr. Balvi?
Yeah, it's perfect and a very comprehensive lecture. So the question is that IVUS is such an important tool that it is being underutilized, and without really understanding where you are, it becomes very difficult. You keep trying in one direction and you may be completely out of the way. So IVUS makes life actually easier than what we think. We don't use it the time it takes, but it actually reduces the time of contrast and the time of the procedure. So it's very important to understand that IVUS is a very, very important tool in such a situation.
And very good to the comment the chairperson has made. I believe that in contemporary reverse cut actually doesn't really make much difference as to whether both the wires are true, whether true lumen or in the false lumen. The only issue is that if there is a big calcium chunk and then your wire is going to knuckle around different parts of the calcium, then connection becomes very difficult. Then you actually have to move the base of operation. Then if your retrograde wire also is in the subintimal space, you end up creating a very large subintimal hematoma or subintimal space, which you end up in a full megatal jacket. That is the only worry. So I try to keep at least one wire try to be in the intralumen. That becomes very easy for me to even to make the IVUS and then to the subintimal space, know which way to direct.
In fact, I have a very low threshold of using guideliner or guidezilla antegradely, because then your externalization is into the guide. Sometimes what happens is your externalization may be in the aorta, then you have to use the snare technique and all becomes cumbersome. So, guideliner does help.
Yeah.
Thank you.
Thank you.
So we go on to the last tutorial on the use of dual lumen catheters, which have become a norm, and I request Dr. Hamazaki to kindly present.
Thank you, Chairman. My team is Crusader and the WMCC. This is the structure of a Crusader. As you know, Crusader and double lumen catheter has OTW lumen and monorail lumen. So, from this characteristics, this device is very useful for complex PCI. And the indication for Crusade and the double lumen catheter in CTO PCI, first is a parallel wire technique. This is a, let me show some case. Target region is LED CTO. The target region is here. And the Gaia first supported microcatheter was advancing into the false lumen. As you can see, that way is here. The lumen is the right left side. So in such situation, a parallel wire technique with double lumen catheter was used. Double lumen catheter could provide better backup support and guide wire controllability because first guide wire was in the monorail lumen. Double lumen catheter. Finally, Gaia second could be advanced, get distal to lumen. So, and the next indication is the CTO with the side branch. This is the target region is LCX CTO with side branch. Target region is here. First guide wire was inserted into the side branch, and the Crusade was inserted over first guide wire, and then second guide wire was inserted through OTW lumen to get entry point of CTO. In this situation, position of Crusade is very important. To get entry point, enough margin between entry point to and export of guide wire, exit port of guide wire is necessary. The enough margin is necessary. After guide wire could get entry point, just like this. Better backup support was necessary to advance guide wire into CTO. Therefore, Crusade was advanced deeply to get better backup support, just like this. You can see. Finally, guide wire could get discharged to lumen. This target region is LMT CTO. This was a demonstration case of NIC last year. Antegrade guide wire could not be advanced into CTO, and retrograde approach by septal channel was used. Chip injection from retrograde side showed CTO with side branch from retrograde side, like this. And the guide wire supported conventional microcatheter could not pass CTO because of lack of backup support and guide wire controllability. You can see. And the microcatheter was exchanged into Crusade, and the Crusade could be advanced into LED from RCA via septal channel easily. Second guide wire through OTW lumen of Crusade could pass CTO because Crusade could provide better backup support and guide wire controllability. And the next indication is wiring for collateral channels. Target region of this patient is RCA-CTO, and the collateral channel exists. This, but as you can see, LED was tortuous vessel. It was very difficult to advance guide wire into target septal branch because of tortuosity of LED. And then double lumen catheter was used. Yeah, this is a double lumen catheter. Double lumen catheter could be advanced into the septal channel easily. Second guide wire supported double lumen catheter could be advanced into the target septal channel. You can see. And the second guide wire could be advanced gradually. And then microcatheter was exchanged from double lumen catheter into conventional microcatheter. Finally, guide wire could pass this septal channel. Next indication is the wiring for bifurcation beyond CTO. In some cases, angle of bifurcation is very large, and in some cases, guide wire make a shortcut at the bifurcation. So in such situation, it is not easy to get the branch. So in such situation, reverse wire technique is very effective. Target region is RCA-CTO. This is the target region here. And the guide wire could pass using a parallel wire technique with Crusade. However, guide wire could not be advanced into PD branch, although a Crusade was used because guide wire in PL made a shortcut at the bifurcation. And then reverse wire technique was used. Crusade and beyond bended guide wire in OTW lumen of Crusade was inserted into PL together. Crusade and bended guide wire were pulled back. sorry. And the pullback, and then guide wire could be advanced into PD. After that, microcatheter was exchanged from crusade into conventional microcatheter. Guide wire could be advanced into PD deeply. So, final CAD showed a good result. So, I had one case, but I'm sorry, my time is up. So, my summary is on slide, and the take-home message. The more complex the treatment, the more useful crusade is. Thank you for your attention.
So I have a comment and a question. So the comment is that this is a very useful catheter, not only for CTO but for bifurcation lesions where you're not getting across the diagonal. And this reverse wiring is a very good technique. And one should keep in mind what has been just said, that the proximal marker is such an important marker that you have to keep manipulating so that the wire slips in. Otherwise, if you don't concentrate on that marker, you will miss from where it is. My question is that once we get the wire through the OTW lumen, we have now two wires. And if you're doing a bifurcation now, we want both the wires to be retained. Sometimes what happens is that the wire from the monorail tends to slip out while you're trying to remove the crusade catheter. So how do you prevent that to happen?
In Japan, we have trapping balloon. So, if you use a double lumen catheter, trapping technique
Yes.
should be used.
Right. So
Yeah.
even before you get the trapping the catheter into the guiding catheter, the wire through the monorail system tends to slip out because you can't push both wires inside. So you're trying to remove the crusade catheter to trap it. So you're pulling it to the guiding catheter. So what happens is the balloon through the wire through the monorail tends to come out.
But we always use a trapping technique with a crusade. So,
The trapping, what he means, when you'll be using trapping once the crusade comes into the catheter. That only after that you'll be able to trap the wire. But what the question is, when you're trying to get the crusade into the catheter, at that time the wire might slip back. How do you prevent that?
Balbir, actually what I do is I ask the assistant to see that he is pushing the monorail wire at the same
so
time.
you need two people.
You require two people.
So this is what
you
said.
remove through the central lumen.
Yeah, central
and
lumen
your assistant will push the monorail wire. That is how.
you need two
But I don't know if there is a trapping will come into picture unless the guiding catheter.
Of course, before you use a trapping balloon, you have to keep the guide wire.
Yeah.
Now,
Thank you.
another question, Dr. Hamadaki. The central lumen of the catheter is actually on one side of the catheter.
Yes,
Does it
right.
make a difference whether it is towards the wall or whether it is towards the lumen? Do you try sometimes to just
No.
Doesn't make a
hole-
difference?
Direction of a hole is not important. Yes.
Okay.
This is not necessary to
Rotate.
rotation. Yeah.
Thank you very much. It's wonderful actually.